you can use, of course, the arrow. Okay. Right here. Okay. Okay. It's up to you. I mean, just want to make sure you're. You don't have to say anything. I will call you. I think I need to show this video. A couple of them.
Okay, so I'm gonna leave this
Okay.
here.
Yes. Mhm. Thank you. It's comfortable, you know. That's my main thing. Just for comfort. So I think it's okay. It was good. Yeah, it was no fun. I went to the Cheesecake Factory. It was a little bit of a wait. Southern, south of the state, in the state, but I mean, I've been in this area. I say Illinois because I've lived all over. Okay. Is this supposed to start at 9:35? Okay, okay. No, no, you guys got it all. Okay. Right, I saw. I'm like, who is that? Is that okay, okay, okay. I offered, he said, to call it.
Hello? Okay, it works.
I think it's on, yeah.
while you're dealing with things that they don't describe.
Good morning, everyone, and welcome to the final day of Family Medicine Midwest 2023. I'm Andy Oak, a student member of the Family Medicine Midwest Board of Directors. We hope you enjoyed all the workshops this morning and throughout the weekend, as well as a variety of breakout sessions and posters. That masterful array of education was reviewed and selected by the FMM Education Programming Committee, co-chaired by Dr. Jonathan Dickman and Dr. Lisa Pfeiffer. If you love scoring abstract submissions, we have a place for you at the 2024 Family Medicine Midwest Conference. Thank you to our Conference Planning Committee, co-chaired by Dr. Sophia McNeese-Ruffin and Dr. Rebecca Lara, who spent months planning every aspect of the conference. Those dedicated volunteers bring the conference to life each year in each location. Everyone from the committee, please stand up so that we may see you. Finally, thank you to the FMM staff who put all those jigsaw pieces together to create a great schedule and a fun weekend for everyone. And a big thank you to everyone who presented throughout the weekend. Let's continue to support our Sunday presentations right up until the conclusion of FMM 2023 with our presence and our feedback. As a reminder to all of our student attendees who are receiving support funding, you need to submit your conference evaluation. And we want to hear from all of our attendees as well. So use the event evaluation button on the app to submit your overall conference feedback. And also please use the short breakout session surveys for each one you attended. You'll find the button and the schedule listing for each session along with speaker information and session handouts. Active physicians will use the Claim CME credit button to submit for their CME credit after the conference. And now please welcome this year's conference planning co-chair, Dr. Sophia McNeese-Ruffin.
Good morning, good morning. Thank you. I'm so happy to introduce the final plenary presentation because it means we're almost at the end of the conference and my responsibility as co-chair will officially be complete. Dr. José R. Sánchez, the President and Chief Executive Officer of Humboldt Park Health, is a senior healthcare executive with over 40 years of experience in operational, strategic, and fiscal management of multifaceted healthcare systems. Most recently, the hospital completed a major rebranding initiative in January 2021, renaming the hospital Humboldt Park Health to reflect the diverse and inclusive community it serves, along with its tagline, Advancing Health Equity, to emphasize the importance of this objective and their renewed commitment to ensuring all members of the community have fair and just opportunities to be as healthy as possible, regardless of their race, ethnicity, or zip code. Now to provide a non-AI generated look at the future of family medicine, welcome Dr. José Sánchez.
Can you hear me?
Good morning.
It is indeed a privilege and an honor to address all of you this morning. I will be remiss if I do not thank Dr. David Ansel from Ross University, who actually recommended that I will be addressing this group this morning. At the same time, I wanted to take this opportunity to really thank a few of my colleagues here who actually came and got up early in the morning to support me, Dr. Dagoberto Camacho, who is sitting, stand up, who is the Chief of Outpatient Services at Humboldt Park Health, and of course, Dr. Samir Shahim, who is the Program Director of the Family Residency Training Program at Humboldt Park Health. And of course, I understand there are 3 residents that are actually part of our program. Can you stand up? They are there right in front of us. Thank you for actually been here. I am delighted to be here with all of you this morning. I hope that through our time this morning, I'm able to share a lens from my own experience of a safety net hospital on the work that you are doing and some of the work that we are doing today. I have been in healthcare for quite some time, and I think I will be able to share some of my experiences. And I have to say to all of you that there are no experts in healthcare today. And that is simply because we actually are facing tremendous transformation and challenges in healthcare and put all of us at the same level. No matter how experienced you are, how long have you been around, today it is an environment that is uncertain and actually extremely challenging. Today, I would like to, let me see if I can change begin by giving you the history of family medicine and the current state of the practice of family medicine. Then we'll talk about things that are actually shaking up the healthcare industry. We'll also talk about challenges and opportunities that exist today, and what are some of the challenges in adapting to an environment as you all are physicians and actually are completing your training. And then we'll talk about some of the successes and a strategy. At the end of our time together, you will walk away with some insights into the evolution of family medicine, identify ways in which you can continues to complete your training and practice medicine, and perhaps the most dynamic times in healthcare history. And that my shared experience will help to forge multidisciplinary collaboration as you continue your career as physician. I am honored to be here because from someone who is not a physician, I have been asked to talk to all of you. However, I've been in healthcare for many, many years, and you could see. So let me give you kind of my background, how I end up in this field. I am a frustrated architect. I wanted to be an architect, so I went to City College of New York for 3 years, and I find out that that was not my call. And because of circumstances, I actually decided to continue my college degree, and I earned a BA in psychology from City College of New York, and then later on, actually, unplanned, I ended up getting a master's in social work from Adelphi University in Garden City, New York. I was awarded 2 honorary doctorates in 2009 and 2022, respectfully, from the New York College of Pediatric Medicine, St. George University Medical School. Both are recognitions of my contribution to public health throughout my career. During my time in New York City, I had the privilege to work for the New York City Health and Hospital Corporation, and I ran 1/3 of the public health care system in New York, which is probably the biggest public health care system in the country, when I was responsible for 3 hospitals affiliated with 3 different medical schools, 23 clinics, 2 of the hospital were level 1 trauma centers, and with an operating budget of $1.2 billion and 9,000 employees. After 16 years there, I began to develop an interest in something else. And I got a call from a recruiter who actually asked me if I was interested in coming to the city of Chicago. And when I came for the interviews, I felt that I was connected to the community of Humboldt Park by looking at the people that lived there and by looking at the flags. And actually, I was very much connected with the experiences that I had in New York, working in Central Harlem, East Harlem, and the South Bronx of New York City. So I decided to take the opportunity from a hospital that was actually very, very challenging. It was a hospital that was just about to fail and closed. I wanted to rebrand myself as a turnaround CEO. It was hard work, but it gave me the opportunity to do so. And then 13 years later, I continued to be the head of Humboldt Park Health. It has been probably the most rewarding job that I have ever had in my entire career. When you take something from the ground and bring it up. And here we are today, actually thriving as a hospital. For over 130 years, Humboldt Park Health has provided quality, affordable, and compassionate health care to some of the most disinvested and underserved community on Chicago's West Side. Today, I am proud to say that Humboldt Park Health is one of the strongest, if not the stronger, safety net hospitals, with no offense to anybody who's in the audience who's working in a safety net hospital who is in Chicago. But I think when I look at the finances and the quality, and the reason that I'm saying that is because I'm very much involved in the fabric of healthcare in the state and in the city and nationally. So I served on the Illinois Hospital Association board, part of the executive committee, served on Region 5, American Hospital Association, okay? And then I spent a lot of time in Washington, D.C. advocating for funding and policy changes. That's why I say that Humboldt Park Health is one of the strongest safety net hospitals today. Back in 2010, when I was asked to take over the hospital, I actually really focused on 5 different strategy or pillars which I considered were the foundation of a transformative healthcare hospital safety net. So I actually really focused on financial stability, quality improvement, physician engagement and recruitment, community engagement, and technology. And those 5 areas are not totally silos. They are totally depending or interrelated with each other. For example, when I first arrived there and the hospital was just about to close, I spent a lot of time going out into the community trying to recruit physicians to join our network of doctors. And every time I met with a physician, they would say to me, why would I send my patients to you when your quality is poor? At the time, we had an F in the leapfrog score. Those of you know what that really means. So one day I went back to the hospital. I got my senior leaders in a room, and I said to them, I am not going out any longer to recruit physicians simply because we need to fix our problems internally. We need to improve our quality. After months and a year, our quality actually went up. Our LeapFrog score went from a F to a C to a B, and we're still trying to get an A, as you know. And then later on, those physicians that I approached actually came back and they wanted to be part of us. Why was that important? Because when physicians actually send patients to the hospital, they want to make sure that patients are well taken care of. At the same time, they want their patients to be satisfied with the care that the hospital is actually providing. So when I think about the financial stability of the hospital was related to the quality improvement that we made in the hospital. And then we were able to get other physicians to join the hospital. Community engagement, which was also, you need to be visible in the community, you need to be able to ensure that people know who you are, and then you can talk about what's going on. And then I take, for example, technology. Technology is also related to different areas. For example, it creates efficiencies, so impact your financial stability, and also improve your quality. So when we talked about the transformation of the hospital, all of these 5 areas are related to each other, and that's basically what happened in healthcare. However, back in 2021, I think during the introduction, we decided to change our name to be much more relevant in today's healthcare environment. So we changed our name to Humboldt Park Health from Norwegian American Hospital. And we moved away from using the word hospital because we really want to focus on wellness rather than treating diseases in the hospital. And when we talk about hospital, it's associated with something that is wrong with somebody. So we actually wanted to move away from that. However, after the pandemic, the inequity in healthcare actually brought the attention that we needed to really to focus on equity healthcare. And by the way, I forgot to mention that Dr. David Ansel wrote a book which is called The Death Gap, that I think you need to be able to make a reference and read this book, because he really talked about the inequities in healthcare and the impact that it has had in the west side of the city of Chicago. So we adopted the tagline, Advancing Health Equity. We continue to pioneer our mission of addressing the most challenging social determinants of health in the Humboldt Park community, including food insecurity, transportation, violence, and affordable housing. Some of the studies that you read today talks about actually the contribution that you physicians and we as hospital provide to the well-being of individuals. It's only 20%. The rest of people wellness and well-being is related to what kind of lifestyle do they have, what kind of food do they eat, where do they live, okay? And you could see, for example, there are communities in Chicago that they are 20 minutes away from the center of the city, and the lifespan is 20 years. You could imagine you drive 20 minutes to the center of the city of Chicago, and depending where you live 20 years less or 20 years more. And that has been proven there. So I wanted to mention to you that where you live, how you lived, depend how long you're going to actually last. Born out of this mission to advance health equity, which is one of the largest initiatives we have undertaken, investing in the first of its kind, 45,000 square feet, a wellness center at a cost of $30 million. I worked on this project for about 5 years, trying to get the funding which we got from the state and city, as well as hospital funding. This will be one of the most transformative projects in the Humboldt Park community. The facility will include an indoor swimming track, swimming pools, rehabilitation services, mind-body integration. It will really follow one of the principles of healthcare in the future, and we will be addressing health disparities. The Wellness Center will bring to the community of Humboldt Park something that they never had. State-of-the-art services focus on education, prevention, and comprehensive wellness. Bringing this project to fruition help Humboldt Park Health solidify all of the elements of creating a healthier, more resilient community. As thrilled as we all are that the Wellness Center is coming to life with each day, we understand that its success is directly linked to our family residents, medicine physicians. Let me talk a little bit about the history of family medicine. Family medicine physicians have worked in rural and underserved communities like Humboldt Park. For this reason, we have been committed to building a robust training program that includes providing our residents with a complete immersive training experience by which they can both train and live in the community they serve. I believe those 3 residents that we have here, they live and walk just feet away from the hospital. So they live in the housing that we built to actually create a pool of physicians that are right in the community. In many of these poor communities, there are no doctors. No doctors live there. I want to commend you for taking the responsibility to say, I'm going to be part of this community. Thank you so much for actually being there. Let's talk about the training of family program. Our family residency training program, actually, trying to click, I got to move forward. So I'm very proud of our training program. So we have 18 residents, okay, and we have the head of this, And I guess what makes us so proud is that all of our residents that have graduated from our program actually have passed their boards in the first try. That's pretty telling. If you take your board and you pass the first try, that says that our program is actually doing well. I want to thank Dr. Shaheen for his leadership, making sure that we have a great training program. My experience is that we have been able to recruit the most dedicated and talented individual to make a difference in a minority community. I will give you an example of something that happened. The first class of our family residents, where we have high incidence of diabetes, probably one of the highest in the whole area in the city. So we had an empty parcel of land, and it was a group of the residents who came over to see me, and they say, that parcel of land is empty. Can you lend it? Can you give it to us so that we could create a community garden? And we still have a community garden. And that was an idea to teach the community to eat healthier. So the residents were interacting with the community. Today, that's one of the most proud programs that we have ever had. So let's talk about the history of family medicine, which many of you probably know it better than I do, especially if you have been a practicing physician for a very long time. Family medicine was first recognized as a discipline by the American boards in 1969 with actually 4 objectives. Now, in preparation for this discussion here this morning, I actually have been reading a great deal about family practice, and there are dates that are not consistent. Some says 1966, some are saying 1969. So if any of you in the audience actually have better information than I do, I would love to hear from you. Just let me know, Mr. Sánchez, you are wrong. It is 1969 or 1966. But anyway, when it was actually formed and recognized as a discipline, it has 4 objectives: to serve as the physician of first contact, to evaluate the patient's total health needs, to develop a responsibility for patient comprehensive continuum of care, and to accept responsibility for the patient's total health. Major charge for you as physicians and doctors to take care of the patient and to be the first contact in the healthcare system. Back in 1975, there were 259 family residency training programs in the United States. By 2022, there were more than 75 approved family residency training programs, consisting of a total of 16,700 plus a slot for training. A significant growth and actually in family medicine. Today, family medicine physicians represent 1/3 of the physician workforce in our country, and they still remain the first point of contact for patients into a healthcare system. With the growth of family medicine training program, a change in family training practice was inevitable. A 2004 collaborative publication of the Annals of Family Medicine reflects that restructuring family training practice were discussed in order to meet the need of patients in today's changing healthcare environment. By 2010, the Department of Health and Human Services and the Council of Graduate Medical Education recommended that 40% of the physician workforce be comprised of primary care physicians in order to obtain optimal health benefits to our patients. Again, national recognition of your practice as family practitioners. However, in 2021, the Accreditation Council for Graduate Medical Education reports indicate they revised the program to consider the impact of diverse communities and program and identify actually 7 themes and a strategy. Community focus as number 1, 2, holistic clinical competent care. I think let me go back. No, not in the 90s, yes. Not yet. 3, long life adaptive learning. And you know, for me, this was quite very important because as a healthcare leader in our city and our state, I always say that the day that you stop learning, you had no right to lead anybody. So when they are talking about long life adaptive learning, I want you to take it very serious, to excel in your career. And if you actually have a leadership role, I think you need to focus on that. Relationship-based communication, collaborative team-based leadership. You are responsible for leading your clinical team to take care of patients who have many often chronic conditions. Technology integration and value-driven professionalism. I just talked a little bit about the history of family medicine in the last 50 years plus in our country. So let's talk about the 90s. I think many of you were not even born yet, right? Okay? The 90s is a decade of that birthed one of the largest platforms to revolutionize healthcare and also many industries in our country. It was the time that the internet was born, right? Right? And all of us are so excited about that, right? We cannot live without the phone anymore and being in front of a computer. Even though I talked about physician burnout in a little while, because that has been one of the issues related to burnout during the review of the literature in preparation for this talk to view. So, what are some of the benefits of that World Wide Web? The invention of the internet was the launch pad for the technology that we have today. Patient portals, electronic health records. Actually, during the federal funding was allocated for ensuring that every healthcare system had an electronic medical records. telehealth that we began to experience as a modality of treating patients actually took off during the pandemic, right? Rapid diagnostic reading and result. And today, I remember many of the elderly physicians in the hospital hated the electronic medical records. We had to hire tons of support staff to help them out. They learn it, and now the day when the system is down, I get like 100 calls in 1 hour saying, when are we going to fix the electronic medical record system? Right? It's incredible how we receive something and then we adapt and we cannot live without that, right? Sometimes I'm driving to the hospital and I forgot that I left my phone in the house, and I turn back. Well, I really need a phone to go to the hospital. I'm going to be in the hospital. But anyway, if I have confidence that I need that phone all the time. While technology was at the front lines, we closed the 90s, bustling. In the background was America's deep concern about spending 17% of its gross domestic product on healthcare, and actually fuel an acceleration toward cost reduction and bird-head the conversation about universal health care. And when we talk about health care, we talked about health care from two lenses. One is quality, the other one is finance. Many CEOs make the mistake that they focus only on market share. How many patients are you going to have in your system? Rather than really focusing on quality. So in today's healthcare, we have found that there are two elements in actually what I call the landscape of healthcare. And these two elements actually focus on quality and finances. Let me tell you that right at the end of the decade, in November of 1999, during the presidency of Bill Clinton, the Institute of Medicine published an article called "To Err is Human," titled "Building a Safer Health System." And by the way, this article, this commission report, actually was published before time because it was leaked and it was going to be in the news. So the commission actually was able to publish that very quickly in November. This created a national impact because it brought the problem of medical errors to the surface and heightened the urgency of safety as a priority for organizations and for dedicated research funding to improve patient safety. Based on that report, at least 44,000 and perhaps as many as 98,100 people, individuals, die in hospital as a result of medical error. This is probably one of the most impactful reports in healthcare when we talked about quality. And it's quite telling that over hundreds of thousands of people die because of medical errors. More than motor vehicle accidents in the country, more than breast cancer, and more than AIDS. And when we begin to actually cost out additional care to those patients, loss of income, household productivity, and disability, these medical errors come at a cost to hospital in our nation to $29 billion nationwide. Staggering figure. $29 billion as a result of medical error. Not to mention that patients actually lose confidence in our ability to treat them. And also that, as you know, CMS track patient satisfaction, so it already will have an impact on patient satisfaction. I would like to talk a little bit about the economics of healthcare. And I actually divided it in three parts: patients, payers, and hospital systems. So patients are impacted by economic health policy stipulated by the government and insurance. Patients can experience services being denied or partially covered. Additional healthcare plans apply, co-payment for services. Those fees directly impact the individual who is actually insured. And you will say, why I'm talking about economics? And you're going to see why I'm talking about economics, because you all as physicians need to understand the economics of healthcare. It's not enough to be great doctors and just know about diagnosing how do you treat your patient. That absolutely expected, but you need to understand the economics of healthcare. As a result of actually what's going on in the market, the government has taken seriously, and they have been mandated policy today. For example, what we call in healthcare, price transparency, to defray surprise billing, a public outcry in Washington, D.C., with individuals who are getting surprise bills that they cannot even pay for it. As a result of that, this policy trend requires hospital systems to post the cost of services as an effort to protect our vulnerable patients. People need to know how much they are being charged for the care that they are getting and how much are they paying. According to the Executive Vice President of the insurance business at SunGard, Paul Tidy, the following 5 criteria industrial trend are impacting healthcare payers. There are increasing pressure on profit margins and manual processes, industry consolidations. All of you should be looking at what's going on in healthcare system today, mergers, acquisitions. They are shifting the management of their Medicaid plans. For example, in the state of Illinois, where we are sitting here today, there is only one not-for-profit managed care company. All of the Medicaid program has been privatized. It's in the hands of people that actually don't care about patients. And if you are a physician, you will find yourself oftentimes calling a managed care company, trying to justify to do a procedure in a patient that you as an expert felt that that patient needs. We have seen the expansion of healthcare accountable organization, modernizing their processes and data to reduce costs. And then, at the same time, something that I welcome very much as a healthcare executive, which is covering people. In 2010, the Patient Protection and Affordable Care Act was signed into law on March 23rd by President Barack Obama. A landmark legislation to revolutionize healthcare since the implementation of Medicaid, Medicare by Lyndon B. Johnson on July 30, 1965, also known as the Social Security Amendment, which had been signed into law on August 14, 1935, by President Franklin D. Roosevelt. Both of these two pieces of legislation I consider to be the most revolutionary one. One, Medicaid was created for the poor. Medicare was actually created for people like me who's getting to that age, that needed an insurance after I stopped working, and I'm getting already called for that. The Affordable Care Act provided national insurance to cover 40 plus million Americans that didn't have any health insurance. The full implementation occurred in 2014, but the most significant component was that health insurances could not deny coverage to patients with pre-existing conditions. That was big, because many health insurance will deny patients health care or insurance because health conditions that they had previously. That program has been controversial from day one. There were a number of states that actually embraced the Affordable Care Act. Some embraced it. The state of Illinois actually did embrace it, but many other states did not. And it was even challenged at the Supreme Court. How could it be that a legislation that brings so much good to the health of our nation is being challenged at the Supreme Court level? It's unheard of. As we talk about this program, we have to understand their cost. The more patients you insure, the more it's going to cost. And this is something that you're going to love. If we take the cost of healthcare globally, I'm talking about worldwide, okay, the total cost is $6.45 trillion in the world. Here's something that you need to know. The United States account for almost half of that total cost. 44.3% of the total $6.45 trillion, which represent approximately 20% to date of the gross domestic product of our country. we as a nation spend more per capita in healthcare than any other developing nation. Now, listen to this. Just listen to this. However, our country that spent half of the total cost of healthcare in the world and spend 20% of their gross national product, rank 17 in patient outcomes. 17. And I believe, someone who has been in healthcare for so long, is that we spend so much in healthcare because we have a broken system. We have a fragmented healthcare system. We have a system that is about competition. If I have an MRI, the other healthcare system get one that is bigger than the other one. There is no coordination of care in our country. We lack comprehensive coordination of care within the spectrum of service. Adding to the economic of health is also other things. That there is an uneven distribution of the kind of dollars that we spend as a nation, okay, in biotechnology and pharmacy. They take one of the biggest chunk from the healthcare system as well. As a result of all of those costs, the government changed the financial model, which moved us from a fee-for-service to a capitated system of care, creating the rise of managed care company in our country, with the goal of reducing costs, but not to improve quality. One of the examples of that is the Medicare Advantage that was proposed by the government. While several elements affect our current healthcare landscape, I will actually focus on three specific areas today in healthcare. One is behavioral health. Two, the focus on health disparities. And last but not least, technology. Behavioral health has been actually not being given the priority and the importance for individual well-being. The pandemic brought this to light in a more resounding way that could no longer be ignored. Currently, there has been a coordinated effort by various branches of government to support programs to integrate what traditionally has been a stigmatized health condition. And these initiatives are being followed with financial support. These efforts are now embedded within the comprehensive treatment of individuals, both mental and physical health. We at Humboldt Park screen every patient for mental health condition. The second area of focus is addressing health disparity and the need for assessment that could address the social elements that impact the well-being of people. For example, understanding food insecurity, transportation, affordable housing, and environmental safety, to just name a few. We at Humboldt Park right now have an initiative to build 300 units of affordable housing now beginning to really work toward building the first 100, trying to get the funding from the state, because that will make a difference in people's life. And with all of these challenges now in healthcare, we also are facing emerging new providers, right? That actually are challenging some of the work that we traditionally has been responsible for. Who are those? You know them, right? CVS, right? Walgreens, Amazon, new people coming in, well-funded. The reason that they are coming to this is because, in my opinion, they could provide patient satisfaction and conveniences that we as hospitals do not offer. Right? We have a model in our country that patients have to follow what we dictate. Give an example. Trying to open a clinic on a Saturday is a struggle, because we work from 9 to 5 from Monday through Friday, and people don't need doctors. At least we think that people do not need doctors on Saturday and Sunday. Right? Right? You don't. Right? You get sick any other day, Monday through Friday. Saturday and Sunday, nobody gets sick. Wow. Don't you love that one? So these are one of the areas that actually we need to fix. Now, technology. You know, I did a lot of research for you guys here. I want you to know that. I spent days reading articles to be able to give you data and information to take away from you, because when you are a physician, you need to understand what are you doing. You're working in hospitals. People like me are making decisions about the hospital every day, right? And I need your input and your feedback on the things that I do. Most CEOs, they think that they could dictate everything. But you could tell these two gentlemen here that work with me, how they walk in my office and they tell me, we want to do this. And I say, well, I'm not in agreement with that. But if you guys take the responsibility, you go ahead and do it. That's the attitude that CEO today needs to have in this environment. So, according to a renowned futurist, hey, you know I have a Spanish accent, right? Who doesn't know? Raise your hand. No one. Trends and innovation expert Jean Carroll, technological development, relentless in innovation are the two key trends that will provide a massive transformation of our healthcare system in the future. Who has not heard about AI? Raise your hand. Nobody? Okay. Artificial intelligence, as controversial as it could be, or what we consider augmented intelligence with the healthcare field, is a platform that allows us to gather broader data, take a deeper dive into person's diagnosis, and synthesize information in a more expedient way. This rapid advancement of technology, especially AI, has an impact in everything that we're going to do, especially you as family residents. According to the Academy of Medicine Journal of the Association of American Medical Colleges, residents spend more time interacting with technology than in direct contact with patients. I don't know that. I hope it's not. But that's not the training. Or you all spend a lot more time. in front of a computer than actually sometimes being with patient. This recent study highlights two significant factors by you all being in front of a computer all the time. There are inefficiency in electronic health records that require improvement. I hear oftentimes from physicians how many times they have to click to go to where they want to be, right? So that is inefficiencies in a system that we use and depend on, so we need to fix that. And the other one is that extended time in front of the computer exacerbate burnout, right? And I'm almost certain that many of you went to medical school to be doctors, to take care of people, not to spend your time in front of a computer. I would think so, right? I reviewed a number of studies for this conversation here today. We suggest that burnout costs the United States economy approximately $5 billion each year. There is a clear consensus that supports the contention that burnout adversely affects physicians, patients, and other healthcare professionals. According to an article of 2019 in the American Journal of Medicine, tens of thousands of people die as a result of preventable medical errors. And burnout is actually one of the exciting. A study by the Center for Effective Medicine in Plano, Texas, in 2018 found that 42% of 15,000 physicians responding to an online survey reported experiencing burnout, and incidents of burnout increasing physicians between the ages of 45 and 54, and I don't think any of you fix that category in here today, right? Another study in 2019 found that 44% of physicians feeling burnout and 14% reporting suicidal thoughts. Serious data that I think we need to focus on. I came across an article that I'm going to suggest that you read it. It came out of Mescape. It says, "I cry, but no one cares. Physician Burnout and Depression Report 2023. Please read that, and you're going to actually enjoy the reading. This article talks about the top specialists experiencing burnout: ED, internal medicine, pediatrics, OBGYN, infection disease, and, of course, family medicine, the profession that you are. Another meta-analysis of 42 studies indicate that more than 42,000 physicians found that physician burnout double the rise of adverse patient incidents and poor quality and decreased patient satisfaction. While burnout is a challenge, I believe that in our industry, we need to really pay attention to physician burnout. I think I'm almost to that time, right? How am I doing here with time? Okay, I'm okay. So let's move on to talked about physician burnout. Let me move into Let's talk about strategy for success. Okay, because that's what you want to hear, right? You don't want to hear all of this data about cost and what's going on, but I think will be helpful. Stay abreast of medical advancements. Continuously update your medical knowledge and skill by engaging in lifelong learning. Stay informed about the latest research, guidelines, and technological advancement relevant to family medicine. Embrace digital health tools and telemedicine to enhance patient care and communications. Embrace interdisciplinary collaboration and cultivate patient engagement and communication skill. Foster strong relationship and collaborate with especially nurses, pharmacists, and other healthcare professionals. I got to tell you, your support staff is key to your success. Love your nurses and love the people that work with you. Don't believe that you are the physician and you make all of the decisions. Work with them, right? You know, I was with a whole bunch of young male physicians the other day. We went out to dinner, and they were talking about, some of them are single, and they started saying that they are not going to marry another doctor. They're going to marry a nurse because they make more than they do. So be nice to the nurses. I spend a lot of time with all of these young doctors all the time. Adapt to familiarize yourself with emerging healthcare models such as accountable care organizations, patient-centered medical homes. Dr. Camacho actually was able to get us certified for 5 years, right? Thank you. Understand the changing reimbursement landscape. Okay? Prioritize preventative care and population health. Place a strong emphasis on preventative care, health promotion, and disease prevention. Advocate for primary care. Be an advocate for the importance of primary care physician in our healthcare system. Engage in leadership and professional development. Seek opportunity for leadership role within your practice, healthcare organization, or medical society. And lastly, I will say, take care of yourself. At a time that everybody talking about physician burnout, take care of yourself. Prioritize self-care, maintain a good work-life balance. Find ways to cope with stress, such as exercise, hobbies, and spend time with your loved ones. Seek support and connection with colleagues and utilize resources to prevent burnout. We need you healthy as well. Our communities, our country need you healthy. I got to tell you, during the pandemic, you know, I call these two young men here the SARS of COVID. Two of them have families, 2 children each. Those doctors came to work every single day. Never stopped. And thank you for that commitment. I want to finish. By saying thank you to all of the physicians that I have come across during my career for helping me to be a better CEO. Thank you for your contribution. Thank you very much.
Thank Thank you, thank you, thank you so much, Dr. Sanchez. Before we dismiss you to your breakout session, a reminder to this year's planning committee that anyone who is interested in working on next year's conference, join us at 1 p.m. in room 164 for the wrap-up meeting.
I have to give you this. Thank you, Doctor.
It was so jam-packed. Lovely. I said I still want to hear more about what you have to say. It's amazing what you're doing.
It's a pleasure.
Thank you. I have to talk to you about your program, too.
I want to eject.
You must go now.
Let's see, eject.
Were they trying to wrap in this?
We're done in here. Yeah. Yep. I'm going to delete the video off of here, too. Good job with that, Ginny. That was fantastic.